I'm going to burn through a lot of the slides. Uh-oh, we're recording it. I got to not drop any F-bombs or anything, I guess.
I'll edit it out.
Yeah.
All right, we are at 12:30. So why don't we go ahead and get started as I keep admitting folks. So this month, really looking forward to this. We have Dr. Mike Towbin and Dr. Karl Steinberg, and they're just going to discuss some hospice issues in long-term care. And I think we decided that Dr. Steinberg is going to kick this off, and he's going to be discussing advanced directive issues. And then Dr. Towbin, you can just start right after him, and he's going to focus on some of the problems that we run into with CMS and CDPHE regarding policies and regs that sometimes collide with hospice practices. So with that, Dr. Steinberg, I will let you begin.
Great, thanks. Thanks for having me. And I've got 40 slides. I'm going to try to get through them as fast as I can. I'm wearing a Colorado relevant shirt. Just thought you might want to see that. And let's see. Excuse me. You didn't just see me cough onto my hand. There's nobody else around. So advanced directives, and I hope this isn't too remedial for some people, but it's always good to check and make sure people do have an advanced directive. It's important. Arguably, the most important thing is to designate a decision maker. And it's a great idea to have people bring those in, when they come into the nursing home. A couple of little grammar and usage reminders. It's an advanced directive. There's no D on that. So you can be a jerk like me and correct people when they use that wrong. Also, a power of attorney is a document and the power that it conveys. It is not a person. So if you refer to people as a power of attorney, please stop doing that. A little something about advanced care planning. Many of you, I'm sure, aware it's come under attack these last few years with Sean Morrison and them. Comparing it to your family's old Pinto that just keeps breaking down. You keep pouring money into it. I don't think it's controversial, and I think those of us who work at the bedside in nursing homes would all agree that it has incredible value, and whether or not you can capture that in a research study doesn't render it not of value. Some of the things that we can do, and one of the things that research has shown most is that it alleviates the distress of family members when they can feel comfortable that they are making a decision on behalf of their loved one that is what they would have wanted. A little about National Pulse. I'm the president of the National Pulse Collaborative now. For me, Pulse was a game changer. In the old days before Pulse, we'd have these big, long conversations at the bedside. Somebody would say, yeah, I don't want to go back to the hospital. If my heart stops, I don't want resuscitative efforts. And that would be valid within the four walls of the building. But as soon as they went home, it was as if that conversation never occurred. So Pulse was really, a big game changer. You take it home, put it on your fridge, and then presumably you won't get non-goal concordant care. So I guess the timeline, I'll make these slides available. I think I put them in the chat box if anyone wants them. Pulsed is an order set, right? It's not just a form. It allows people to identify their goals. And when I say pulsed, I'm talking about most. Get the care you want to get, care and treatment, and not get those things that you don't want to get. And it helps us as providers to determine what a person wants in a particular set of circumstances. This came to being in Oregon in the early 90s. It's been legally recognized since 93, and there's now a pulsed paradigm program in all 50 states and DC. It's legally recognized in some, it's come through statute, in others it's just by sort of common practice. And there are guidelines for pulse forms, and not all of the states meet them. Like Maryland basically makes it mandatory for a nursing home resident to have a pulse form. And some states don't require that the patient sign it, only the doctor has to sign it, and some other sort of weird things like that. And some still have antibiotics on them. The Colorado form is I should have made that green, I guess, is pretty closely modeled after California's form, and incorporated some changes that I'll show you in a minute that we made in California very soon after that. And I think there's been more of a move toward electronic implementation, which I think is a good thing, especially for first responders and for community dwellers and that sort of thing. In the facility, it's not going to be hard to find a pulse form or a most. They should be updated periodically, and when it's updated, there should be substantial and significant improvement, not just wordsmithing. We've moved away from using pulsed, which originally was physician orders for life-sustaining treatment, for a couple of reasons. One being that life-sustaining treatment is a little value laden, right? Because doing CPR on a 70-pound, 100-year-old probably is not life-sustaining. And also because it's not all physicians. So you have a much better name in Colorado, medical orders for scope of treatment. That's perfect. That's, if I could go back and rename our form, that's what I would name it. There's lots of names across the states. My favorite is T-pop. Sounds like a rap singer or something like that. And just a little something about the penetration of pulse. You'll see Oregon is white. That's because they seceded from National Pulse for a variety of reasons. This is the National Pulse model form. It's a pretty good form. It's very similar to what we have. The stuff about the surgically placed feeding tubes is a little weird, and so when we go to change it, I think that will be changed. Here's your form. Nice form. I guess the thing about race and ethnicity, that's an unusual thing that most states don't have. I don't know if that's to help a first responder feel confident that they've got the right person, but that is a strange thing. Otherwise, good form. Pulse is not for everyone. If there's one take-home message, I hope you're not doing these routinely on all nursing home residents, and if you are, please stop doing that. Down here is a link to the National Pulse document that says who the intended use is, but the surprise question is a good tool. If you wouldn't be surprised if the person died in the next year or two, they're probably pulsed appropriate. Clearly not every nursing home resident. And if somebody just wants default treatment, they should not be given a pulsed form. We don't need a pulsed form for that. You're going to create a conflict down the line if you do. So please stop doing that. I know Colorado also has a DNR form that's short of a pulse. That only applies to CPR in case of a cardiac arrest. When does Section A of the pulse apply? That's kind of a trick question. If patient has no pulse and is not breathing, which, as we all learned in medical school, means you are dead. So people sometimes don't want to sign a DNR because they say, I know what that means. I've seen it on TV. It means you just let the person die, gasping for breath. That's not at all what it means on a pulse form. It only applies when you basically have already died a natural death. So that's a really important nuance that sometimes can help people get clarity on that. And obviously CPR doesn't work very well in our population. If you check yes to CPR, then you must check full treatment. And I see Colorado has the same as what we have and what National has. So I just wanted to show you some of the history here. In 2014 in California, we changed what used to be limited additional interventions to selective treatment, and we changed comfort measures only to comfort-focused treatment, which I think was better language. It did not make people feel like they're giving stuff up. We also added a trial period of full treatment, which you guys don't have there, and that's been helpful because essentially, if somebody says they want full treatment, then 2 weeks later, when you're talking about, okay, they've been on a vent, it's time to consider a trach. If the family says she wouldn't have wanted this, then you're basically going against the pulse, what the person signed themselves. So it's most of the people that I see that check full treatment only want a trial period. They don't want to be kept alive ad infinitum. So I'm going to skip my little hilarious slide there. selective treatment, that's, I don't know about you all, but in my world, this is what most people pick is DNR selective, basically no heroics. I don't want to be flogged, but of course, I don't mind going to the hospital, maybe even go to the ICU, get pressors for a couple of days, that sort of thing. And we do have this do not transfer option for people in nursing homes who say, just do what you can for me here. In other like assisted living, they're not allowed to do that unless you're on hospice. And comfort focused treatment, it should be clear to everyone that everyone gets comfort care, whether or not you check that box. So sometimes people check that when they have a conversation with the nurse, thinking they want comfort, but they don't realize, hey, if you get pneumonia, we may just throw morphine and oxygen at you and no antibiotics, because it's questionable as to whether that's really antibiotics or comfort care. And if somebody has a hip fracture, it may be appropriate to send them to get that pinned so that every time they get turned and repositioned in bed, they're not having that thing flapping in the breeze and they're in excruciating pain. Artificial nutrition. Oregon took this off their PULSE form. Most of the other states have kept it on. You all know that tube feeder is considered contraindicated in advanced dementia. Unfortunately, the American Gastroenterological Society and the American Academy of Interventional Radiology have not made such statements, and they're happy to still plop these tubes in people. And of course, sometimes we get put in that position, but certainly to the extent we can plan ahead and tell people, hey, when your loved one stops being able to eat and drink, we are not going to recommend a feeding tube. And here's your part D of the form. This is some wonderful language that we have in our probate code about, courts not being the proper forum in which to make healthcare decisions. But it's not too relevant. This I found on, Colorado. I was surprised to see this stuff that an attending physician can designate another willing physician to make healthcare treatment decisions. That's really unusual, and it's kind of convenient in a way. But I see that for life and death decisions, it requires kind of an ethics committee, as it should. But I also love that basically the healthcare team can choose out of the person's loved ones. A lot of states have this really rigid hierarchy, which Uniform Laws Commission, in spite of a lot of my and other people's resistance to it, they put these in descending order. So you're fortunate in Colorado not to be constrained by that, where the estranged spouse has more standing than the 4 adult kids who all agree that the person would or wouldn't have wanted something. Obviously, please never sign a blank PULSE or most form. I mean, I shouldn't need to say it, but that's not appropriate. And please, if you've worked with a hospice staff for many years and you are confident that they have appropriate conversations, it may be appropriate for you to sign your name to something like that. But as a general rule, just take the time to verify that the person understands what they signed. PULSE should be updated from time to time. A lot of people never do change their treatment preferences, but sometimes people do. Please document your conversations and make sure you avoid old forms if you're creating a new one. I'm not going to talk about registries, but they're coming, and I think they're a really good thing. Just obviously, if you implement a registry, make sure that that any new form gets uploaded immediately. Otherwise, somebody could be working off an old form. Advanced care planning codes. I just remember that this requires 16 minutes discussing advanced care planning. And, I do a lot of this work, and I have to say, it's not common for these conversations to take 16 minutes. I know I've seen providers who build this on every new H&P. Please don't commit fraud. If you're really talking 16 minutes or more, by all means. If you talk 46 minutes or more, build both codes. But if you're interested, this was a little Jerry Pal podcast that we did recently about the value of PULSE. And there are people out there who don't think it has value, which is surprising to me. With the Dobbs decision, I think we may see some states getting more and more sort of just the right to life type stuff, where we may be obligated. It may be harder to withdraw or withhold treatments that people don't want. So just keep that on your radar. Pulse should not be offered to people that are welcome to Medicare or at an annual wellness visit. And in nursing homes, I think they're way overutilized. If you have people who want to do voluntary stopping of eating and drinking or medical aid in dying, obviously they should have a pulsed form so that if there's any issue, they don't get CPR if the paramedics come. A few pain points, and then I'll wrap up. Sometimes people get sent to the hospital who shouldn't be, and sometimes people don't get sent to the hospital who should be. And so, if you're on call, you get a call on somebody, please, ask if there is a pulse or if there's other forms in there, orders about preferences. Just make sure you consider that. Don't always take the, path of least resistance, which is, oh yeah, just, send the patient in. It's not always a kindness, as you're well aware. DNR does not mean just let the patient die. It means see what part B says. So if you're a DNR and you're gasping for breath, you can still get intubated if you have full treatment. Sometimes nursing home staff will have a family member sign a form, even though the patient has capacity. There's no reason to do that. Please, make sure that the patient signs it. Paper forms get sent to the hospital, never returned. Obviously, you should have copies of those, which are valid. There's lots of, technical errors on the form. I think this is an error. I think if you have somebody that's going home from a nursing home and they have a most form that you've completed with them, make sure they take it with them and also get it into the hands of their primary care doctor, please. Some facilities will give somebody a new pulse form, even if they just did one at the hospital, or even if they had a valid one. There's absolutely no basis for that. They do not need a whole new form filled out. It's just maybe that it's in the admission packet. We've seen questions by other providers about the quality of the conversation and even the validity of the form, which is unfortunate. So it's always good to really document the conversation. And I'd say, again, the biggest pain point is that pulse or most is being done on patients who just want default treatment. These people do not need a most. If you don't have one, we assume you want CPR, you want to be intubated, you want counter shocks. So please don't be doing those. If you get asked to do it, don't do it. Say this patient does not need a most form. And I see that your civic website here has a great little top 10 tips to use in care communities. If you're not familiar with it, it's great. It's got a lot of good stuff. These are some decision guides that the Coalition for Compassionate Care of California has. Very low health literacy, good stuff. Here's some other resources. Thanks to everyone for working in this care arena that we work in. I know a lot of people don't think it's the best place to work, but those of us who choose to work here see its value, its beauty, and all of the love and compassion that goes on every day. And that's it. What time is it? Let's see. Okay, sorry, I went over a little.
That's okay. I'm going to go ahead and share my screen. I hope. Let's see. Share. Oh, heck. OneDrive. Upload your presentation to share. That's not what I wanted to do. All right. Travis, do you have it?
Pull it up here. You just share, and you can share your whole screen if you can bring it up. Yeah, bringing it up here.
Let's see. I don't know why it's making me send it to you now instead of. Yeah, I'm not sure about that. Sorry about that.
There you go. How's that?
Yeah, I think that's going to have to work.
Okay.
Yeah, it's been one of those days that not anything was working right for me. So let's go with it. So I'm going to try and present this in 11 minutes. I've got 18 slides. There's a whole lot to talk about. So I'm just going to cruise through. So hospices, SNFs, CMS regs, harmonic convergence or clash of worlds. I'll give you a quick overview, talk about the tensions that arise, talk about specific areas of conflict, and then a few odds and ends. So Hospice 101. I'm a hospice medical director. I've been one for 8.5 years. Well, actually closer to 10. But if you're not familiar with hospice, I'm sure most of you know these things. 6 months life expectancy is the primary qualifying eligibility requirement. No life prolonging or curative treatments. The hospice is responsible for providing all the medications, treatments, equipment that is related to the terminal diagnosis and prognosis. So we're constantly trying to figure out if things are related or not related. In the nursing home, we have to have a contract with the SNF that also delineates who pays for what. So sometimes the SNF wants to provide the bed, sometimes they want us to provide the bed, etc. The interdisciplinary team is the main unit of care. So it's a nurse case manager, a social worker, a CNA, a chaplain, a volunteer if the patient wants it, or family, and a physician, could be the medical director or the patient's PCP. The overarching goals are comfort and dignity. However, patients may have different goals, plus the care of the family and bereavement services for over a year. At Pathways, we provide services for 13 months. It might look different with different hospices. So something to look into when you're shopping around. Patient is recertified at 3 months and 6 months. So those are the first 2 benefit periods. And then after that, if they're still alive, the benefit periods are 2 months thereafter. And there are 4 levels of hospice care. The main everyday level is called routine care that can be done in home or skilled nursing or assisted living. Respite care is for up to 5 days per benefit period. It's mainly for caregiver breakdown, can be done in a SNF or an inpatient unit. GIP or general inpatient, which is almost like ICU level hospice care where people are getting injected medications or infusions or special treatments, can be done in a hospital or SNF or an inpatient unit. And continuous home care, continuous care can be done at home or assisted living facility. So moving on. So the goals of the hospice, the SNF, and CMS are all slightly different. And so that's where we get into compatibility issues. So the goals for hospice are comfort and dignity for the patient. And the main ethical principles that come into play are beneficence and autonomy. The law of double effect is recognized and considered okay, meaning that there will be times when we are attempting to do something good, but also something bad is happening. Namely, we're potentially accelerating somebody's demise. And that's considered moral and ethical if the goal is comfort. And we use off-label medications and treatments fairly frequently, which is hard to do in a SNF environment. As I mentioned earlier, the interdisciplinary team is the caring functional unit. In the SNF, the goals are welfare and shelter of vulnerable citizens, denizens, and the salient ethical issues are justice, non-maleficence, utilitarianism. So the most good for the most people. They want to avoid tags. They want to watch their quality indicators. And the staffing model is teams, organized geographically by unit or hallway often. And CMS's goal is stewarding government resources and protecting populations. And their ethical goals are utilitarianism. So again, doing the most good for the most people and not doing harm. I'm just going to keep moving because I know there's a lot of discussion we could have here. When we're looking at specific issues, I'm just going to kind of go down the list. So pain treatments. In hospice, we're constantly trying to dose find. So we're using PRN medications, and we're depending on the staff, our families, to get medications right. And in the skilled nursing facility, we often don't want to put undue burdens on the nursing staff to figure out what's the right dosage. The sixth bullet down, this is probably the most important point in all my slides. Avoid dose and time ranges in your orders. So if you're writing morphine 5 to 10 milligrams every 4 to 6 hours as needed for pain, don't do that. In the words of Karl Steinberg, stop doing that. You can write morphine 5 milligrams every 4 hours as needed for moderate pain or dyspnea. You can say 5 to 7 on a visual analog scale or a FLAC scale. Morphine 10 milligrams for severe pain. So you can write these things out so they're clear for the nurses, and that way the nurses aren't going to get into trouble. Short-acting opioids aren't great for chronic pain, so when we can, we want to get them onto longer-acting medicines. Going on to nausea. Again, PRN medications and dose finding are important. And once we can, we want to get things scheduled so we're not waiting for patients to get more symptomatic and need more medications. Often we start with ondansetron, which is a serotonergic medication. It does have an orally dissolving tablet. It can have side effects, very constipating. Haldol, let's see, where do we go there? Haldol is milligram per milligram, one of the most effective treatments for nausea. It is an antipsychotic, so we have to be very clear that we're using it for, thank you, that's awesome, for nausea and emesis. The liquid concentrate works very well. Olanzapine, also an antipsychotic, also a good option, particularly for when you have somebody who's going to live longer and needs longer acting medications. And metoclopramide can be awesome, but we do have to watch out for tardive dyskinesia. Moving on. Agitation, behavioral and psychotic symptoms in dementia. Again, we want to dose fine. We want to do what's right for the patient, but we really need to avoid using PRN benzodiazepines in the skilled nursing facilities. You have to document why a PRN is necessary, and we can only write our orders for up to 14 days. Then they need to be reevaluated in person if we're going to continue those. Very often, I mean, the problem with regular routine dosing is overdosing or underdosing. And so finding the right dosage is the real challenge. PRN antipsychotics are a no-no in the skilled nursing facilities. So usually you have to pick a dose and try it and reevaluate frequently and change things up rather than PRN antipsychotics for agitation. Let's keep going. Wound management, I just want to say here, our goals are rarely to heal the wound. We want to manage pain. We want to manage odor, drainage, expectations. We rarely need a wound specialist or a vacuum-assisted closure or debridement. And sometimes the problem is bleeding and we're just using hemostatic gauze. So just moving on, I think I'm happy to provide the slides because there are a couple of little pearls in there that might be nice for wound, for odor management. Therapies for hospice patients, we often get asked by SNFs, hey, can we have 6 visits to improve strength and balance? Rarely in hospice are we going to want to provide a lot of therapy, but if there's a specific goal in mind, then absolutely. If it's transfer training or evaluation for a better wheelchair or speech diet upgrade or downgrade, absolutely, those are great reasons for using therapies. The hospice is responsible for deciding, and so since we're going to be paying for it, we often have to make those decisions. Next. Sorry, a few quick odds and ends. as the attending physician, you're often going to get asked, how long does my loved one have? Every family member wants to know. If they don't ask me, I ask them, do you want to know? And I always give a range. If you guess an exact time, you'll always be wrong. And remind them to say the important things. Thank you. I love you. I forgive you. Please forgive me, and goodbye. Keep focusing on the goals. Always come back to the goals. What are the goals? And sometimes it's not comfort and dignity. It's wakefulness and being able to communicate with family. Next. Almost done. So hospice in your building, your buildings need to contract with the hospice. It could be a one-off or it could be a long-term arrangement. Vivage Beacon doesn't credential the hospice providers, so all of the recommendations through hospice need to go through the PCP in your buildings. And so just keep that in mind. That's not true of all buildings, but it is for Vivage Beacon. And think of alternative routes for medications. I asked Greg Gom about MACI catheters for rectal administration of medicine. We do that a lot at home. Not every skilled nursing facility will allow it, but will yours, is my question. And have you thought about it? Those are just some things to think through. I think that's it. Oh, and a Foley catheter. Yeah, rectally. Exactly. That's all a MACI catheter is, by the way, is a fancy Foley catheter. But it comes with a grinder if you want to grind your pills, and a little canister to suspend medications in water. And I have time for questions, but we are 1 minute over, so I'm not sure if we can do that.
Yeah, Dr. Towbin, I think, recognizing it's 1 o'clock, people can jump off, but I'd like to stay online for a minute and just see if anybody does have any questions. You can unmute yourself or you can put it in the chat. Looks like Karl mentioned antipsychotics requiring face-to-face every 14.
Yeah, but for a benzo, you can, as long as you document that it's going to be needed, it's medically necessary long-term. That does not have that. For the initial one, it's 14 days, but then you can be long-term on that.
Once you see him face-to-face. Yeah, thank you for that.
Mike, I'd like to ask, do you know regulations as it relates to monitoring weight loss in hospice patients in the long-term care setting?
That's a great question. And I think another question that comes up, and we talked about this in our ethics meeting this morning, feeding as well, encouraging supplements and things like that in patients who we know are dying. I think we're allowed to say we don't want weights checked any longer. We don't want our loved one messed with in that way. But I will also say, if your loved one is going to live longer than 3 months and needs to be recertified, having a weight is really helpful from the hospice standpoint to determine ongoing eligibility.
Okay. Well, these presentations will be available. We'll make sure and send them out to everybody. And I just want to thank both of you for presenting on both of these topics. They've been fantastic. And as always, you guys can email myself or Dr. Gom if you have any direct questions you want forwarded to them. And want to thank everybody, and everyone have a good day.
Thank you all. Thanks, Karl.
Bye. Take care, Mike.
You too. Take care, everybody.